Hi everyone, welcome back to the channel. Today we are going to talk about a very important clinical scenario, how to approach a patient who has a tall stature along with gynecomastia. This is one of the common exam cases and also something you might see in the internal medicine or endocrinology clinics. First of all, when the patients approach you, you have to take a history. So, what are the things you are going to ask in history? First, as a presenting complaint is complaints about tall, then just ask about he has been always this tall from childhood. Just ask him. Then ask about gynecomastia. When it is appear, it is progressive, it is tender. Is there any discharges? Then go for a differential diagnosis for the causes of gynecomastia and tall stature. The four main differential diagnoses are hyperthyroidism, acromegaly, Klinefelter, then Marfan syndrome. Hyperthyroidism and acromegaly will be the cause of tall stature if the causes is before the epiphyseal fusion. So what are the causes for what are the symptoms of hyperthyroidism? Just ask about increased appetite, weight loss, diarrhea, sweating, racing of heart, anxiety, insomnia. For acromegaly, change in facial appearance, change in shoe size, headache, everything. For Klinefelter, ask about the body hairs, axillary hair, and pubic hair, with the history of infertility or not. For Marfan, you generally ask about back pain, joint pain, any visual disturbance such as myopia. Myopia is common in Marfan syndrome. After asking a history about the causes, then go about past history. In past history, you should ask about the any previous admission of patient for any pneumothorax, which is common in Marfan, any hernia, then any lens dislocation. You should ask in past history. Then go to family history. Ask about this tall stature is common among their family. Then ask if there is any family history of aortic dissection or spontaneous pneumothorax in their family, which favors along Marfan syndrome. Ask about family history of any thyroid illness or thyroid surgery, which favors among men 2B syndrome. What are the other features we will find in men 2B is one is hypertension along with mucosal neuromas will be found in men 2B. The close differential for Marfan is homocystinuria. So assess the mental status of this patient and search for the rash. The rash is libido reticularis and any event of thromboembolism, which will favor the homocystinuria. Once you ask the history, then go for examination. Examination should be focused on Marfan syndrome. In Marfan syndrome, you just ask the patient to stand and see the patient is tall or not. Tell the patient is tall with disproportionately long limbs, which is known as dolichostenomelia. How will you tell the patient has a long limb? Check for a arm span, which will be more than height. More than means usually it is more than the height. The ratio will be more than 0.5. Then we will say arm span is more than height. Then pubis sole is more than pubis vertex, where trunk upper body is lower than the lower body. So we will tell long limbs. Then check for kyphoscoliosis. Plus on the chest you will see a pectus carinatum. Then check the hands for wrist sign and thumb sign. Thumb sign is also known as Steinberg sign. So what is thumb sign or Steinberg sign is, you just have to wrap the other hand of the patient with the right hand with their thumb and pink finger or little finger. If the little finger is overlap with the thumb, then it's the positive indication. Thumb sign is positive. Sorry, it's a wrist sign. The thumb sign is, ask the patient to make a fist with the thumb is enclosed by the other fingers. If the thumb exceeds the ulnar border, then it is called thumb sign positive, which is a Steinberg sign. The wrist sign is also known as Walker sign. Then go to oral cavity and look for high arched palate. Once the high arch palate is confirmed, then the differential diagnosis for high arch palates are 4. One is Marfan, then Turner's, then tuberous sclerosis, then Friedreich ataxia. Then go to high and check for blue sclera plus heterochromia iridis. The differential diagnosis for heterochromia iridis are, one is congenital Horner syndrome, then second is it may be come as an inheritance conditions, another is Marfan, then you will see along with this another sign is you will be seeing iridodensis. The differential diagnosis for iridodensis are trauma, chronic uveitis. Iridodensis is a sign of lens dislocation. We can't directly see a lens dislocation in a examination. It will need a slit lamp examination. So it is an indirect sign of lens dislocation. Chronic uveitis, homocystinuria, Marfan, then Ehlers-Danlos syndrome. Okay, after checking the eyes, check a foot. There will be a flat foot. So your diagnosis will be a Marfan syndrome. Your presentation should be like this. On examining the patient is tall with a disproportionate long limbs. The patient has a kyphoscoliosis with pectus carinatum. The wrist and thumb signs are positive, and the patient has a high arched palate with a blue sclera and heterochromiocytosis and iridodensis. And the patient has a flat foot. The findings are inconsistent with the Marfanoid body habitus. The differential diagnosis for this are Marfan and homocystinuria. And I would like to finish my examination with, you should finish your examination with assessing the mental status of the patient, and auscultate for the valvular pathology, where valvular pathology in Marfan syndromes is more common with MVP, MR, or AR. In homocystinuria, there will be no cardiological manifestation. For mental status, in homocystinuria, patient will be mental retarded. In Marfan syndrome, the patient will be normal. So these examinations will be helpful in differentiating the both. Then the examiner will ask how will we proceed with the investigation. Then tell, you should order investigations about. First thing is ophthalmic examination, slit lamp examination. Second is echocardiography, and you will specifically look for aortic root dilatation. An indication for a aortic valve replacement or aortic root repair is where the aortic root dilatation is more than 5.5 centimeter. If a patient has a family history of aortic dissection, then it becomes more than 5 centimeter. We will be prophylactically repairing the aortic dissection, root dilatation. Echo, then we will be ordering a X-ray spine for look for kyphoscoliosis. Then X-ray pelvis. In pelvis, we will be specifically looking for protrusia acetabulae, where the head of the femur is come inside into the pelvic cavity, protruding into the pelvic cavity. Then fifth one is MRI spine. Why MRI spine is because these patients are prone to develop dural ectasia. What is a management will be, all patients should be on beta blocker, restrict the physical exercise. Then if the patient has more than 5.5 centimeter, we will go for aortic repair. If there is aortic regurgitation plus aortic root dilatation, we go for Bentall procedure, where simultaneously we will repair and replace the aortic valve. Okay, these are the investigation and management of Marfan. For gynecomastia, we should rule out whether it is a true gynecomastia and pseudo gynecomastia. To differentiate this, you should have to use your thumb finger and index finger, and you should squeeze the nipple areolar complexes. You will feel a firmed tissue under the nipple areolar complex. It is a true gynecomastia. If there is no such thing, it is a pseudo gynecomastia, which is due to adiposity alone, not a true glandular enlargement. So while presenting your case in gynecomastia, you should present as and examine the middle-aged male patient. There is enlarged glandular tissue beneath the both nipple areolar complex, which is firm, concentric, and mobile. So the diagnosis will be gynecomastia. Then you should evaluate for the causes of gynecomastia. The causes of gynecomastia will include CLD, chronic liver disease. Look for signs for chronic liver disease, and chronic kidney disease. Look for any signs of renal replacement therapy. Then hepatocellular carcinoma. Look for cachexia and other things, and look lung carcinoma. Look for any cough with blood tinged sputum, cachexia, weight loss, and constitutional symptoms of cancer. Then go for hypogonadism. In hypogonadism, there is two types: primary and secondary. Primary is due to testicular failure. where it may be where undescended testis, or it may be a mum's orchitis where a testis is failed and there is no testosterone production. On that case, for a feedback mechanism, LH will be surged, and this LH will convert the testosterone androgen to estrogen in peripheral aromatization. In secondary hypogonadism, there will be even though LH is less or decreased or absent, the adrenal cortex will continue to produce estrogen precursor, which will get converted into estrogen in peripheral tissue. So there will be gynecomastia. Or any testicular cancer that produce estrogen will cause us gynecomastia. And the main last thing is drugs. Look for drugs. Most commonly it will be produced by digoxins. Look for AF. If the patient is AF, then the gynecomastia may be due to the intake of the digoxin, or spironolactones, then cimetidine, then the other drugs such as methyl dopa, fluconazole, finasteride, and much more. So you should evaluate the causes of the gynecomastia also. Like this, you will be assessing the tall stature with gynecomastia patient. To summarize, tall stature with gynecomastia is a powerful clinical flow. Think of Marfan, Klinefelter, hyperthyroidism, and other drug causes. Evaluate systematically with history, examination, hormonal workup, and focused imaging. Always remember to screen for aortic root dilatation if Marfan is suspected. The dangerous complication of Marfan syndrome is aortic root dilatation and aortic dissection. So, annually examine the Marfan patients with echocardiography and eye examination for lens dislocation. The lens dislocation in Marfan is up and outward, in homosexuals in and downward. So, thank you for watching. We will meet in another session.